Okay, so now we're going to talk about pancreatitis. So pancreatitis, there's two types of pancreatitis. So there's acute and there's chronic pancreatitis. So pancreatitis is just the inflammation of the pancreas, okay? So it can happen in acute setting or a chronic setting. Okay, so acute pancreatitis. So this happens in an acute setting, okay? So in terms of mechanism of acute pancreatitis, well, we have these acinar cells in the pancreas. So acinar cells in the pancreas are responsible for the exocrine function of the pancreas. So remember that the pancreas has two functions, exocrine and endocrine function. So endocrine function is releasing insulin and glucagon into the bloodstream to regulate our blood sugars. And the exocrine function is the production of digestive enzymes. So digestive enzymes like amylase, lipase, trypsin. And in the case of acute pancreatitis, we have some sort of process or some sort of agent that causes injury to these acinar cells, and that leads to the activation of the pancreatic enzymes, lipase, trypsin, amylase, that leads to the autodigestion of the pancreas. So that's why it happens. In terms of etiologies, there's quite a lot that can cause acute pancreatitis, but the only one you really need to know for the exams in real life is gallstones. Gallstones causes 4 to 7% of acute pancreatitis cases. And the reason for this is if you think back into anatomy and physiology, we have the gallbladder. So it's actually here. So we have the gallbladder, and from the gallbladder, you have the cystic duct coming off the gallbladder. And then it meets with the bile duct coming from the hepatic duct, sorry, coming from the liver, forming the common bile duct. And this common bile duct again meets with the pancreatic duct. So you can see it here. So this is like the biliary tree. So the gallstones that form in the gallbladder can lodge itself in the common bile duct, and if it lodges itself here in that common bile duct, then it can prevent pancreatic enzymes from actually being secreted from the pancreas. So this is why this causes acute pancreatitis. So gallstones being lodged in the common bile duct, preventing the pancreas from being able to secrete the digestive enzymes. So these digestive enzymes, they stay within the pancreas, they get activated, and they can cause the autodigestion of the pancreas. Okay. Okay, so that's the main cause, gallstones. Remember, gallstones, acute pancreatitis, don't forget. Number 2 is alcohol. Alcohol can cause acute pancreatitis. The next common one is medications. Medications like hydrochlorothiazide. So hydrochlorothiazide is it's a diuretic. It's thiazide diuretic used for, like, let's say hypertension, things like that. Protease inhibitors. So protease inhibitors are your HIV medications. Okay, protease inhibitors are HIV medications, anti-HIV medications. Exenatide. Exenatide is a diabetic, is a used for diabetes. Okay, it's a diabetic medication. Exenatide. Valproic acid. So valproic acid is an anti seizure medication. Okay, valproic acid. So these medications, hydrochlorothiazide, protease inhibitors, valproic acid, and exenatide, can cause acute pancreatitis. But the one you should never forget is gallstones. Okay, so gallstones, alcohol medications like protease inhibitors, exenatide, hydrochlorothiazide, and valproic acid. Okay, so I have a good way to remember everything that can cause acute pancreatitis, and it's I get smashed. So I for idiopathic. So sometimes patients present with acute pancreatitis and we cannot identify a specific cause, so that's called idiopathic. G for gallstones, most common. E for alcohol. Okay. T for trauma. So any trauma, direct trauma, blunt trauma to the pancreas, can cause acute pancreatitis, can cause irritation and inflammation of the pancreas. S for steroids. M for mumps or malignancy, cancer. A for autoimmune. S for scorpion sting. So scorpion sting can trigger injury to the pancreas. Hypertriglyceridemia, so high triglycerides, and hypercalcemia, okay, high calcium in the blood. ERCP, so acute pancreatitis can be caused because of iatrogenic procedures, so procedures that we caused as medical personnel to the patient, so ERCP for instance. And D for drugs, so drugs like protease inhibitors, exenatide, hydrochlorothiazide, and valproic acid, which we already have discussed, okay? Okay, so what are the symptoms of acute pancreatitis? So the symptoms of acute pancreatitis include epigastric pain. Epigastric pain that radiates to the back, okay? And this epigastric pain that radiates to the back is described as boring pain. So it's boring, not in the sense that it's not interesting pain, it's just boring. So you're boring like a hole. So it's like a sharp, deep stabbing kind of pain. Okay, so sharp, deep stabbing kind of boring pain, yeah, okay? So when you're like boring a hole or something. So that's the kind of epigastric pain that these patients would experience, sharp, stabbing, deep pain, and it radiates to the back, okay? And it changes with position. So this boring pain is worse when the patient is lying supine, and it's improved when the patient is laying forwards or in like a fetal position. So again, it's worse when laying completely supine, and it's alleviated when the patient is sitting up, okay, leaning forwards or in a fetal position, okay? Worse when laying supine, better when they lay in a fetal position or leaning forwards, okay? And obviously nausea and vomiting because of the severe pain, you know, it's sharp stabbing, like deep pain. Obviously that's going to cause nausea and vomiting. And fever, because obviously ultimately we have an inflammation going on, it's going to increase your core body temperature. So again, symptoms of acute pancreatitis include epigastric pain that radiates to the back. Pain is described as boring, deep, sharp, stabbing kind of pain, okay, radiates to the back. And it changes with position, worse when laying down and better when sitting and leaning forwards or in a fetal position. Nausea and vomiting and fever typically occur in acute pancreatitis as well. So on physical examination, what you're going to see is the Collins sign. So Collins sign, actually Collins sign and Great Turner sign are very similar, okay? These are signs of abdominal wall hemorrhage, Collins and Great Turner sign. So Collins sign is bruising around the umbilicus. So if you can see here, bruising around the umbilicus, that's Collins sign. It's again sign of abdominal wall hemorrhage. Great Turner sign is bruising seen at the flanks. Okay, so like this. So Collins sign, bruising around the umbilicus. Great Turner sign, bruising around the flanks. Okay, diagnosis. How do we? By the way, guys, Collins sign and Great Turner sign are seen in less than like 1% of the patients that present with acute pancreatitis. Like I myself have never seen this. But the thing is, if you see it, if you see Collins sign or a Great Turner sign or both, this means that the case of acute pancreatitis is very severe, and these patients have high, very, very high mortality rate. Okay, so just remember that. Just because it's not so common doesn't mean that they're not going to ask you that in the exam. They would definitely ask you that in the exam. So remember Collins sign, bruising around the umbilicus, and Great Turner sign, bruising around the flanks. Signs of abdominal wall hemorrhage. Okay, how do we diagnose acute pancreatitis? So we can measure amylase and lipase in serum. So typically, amylase and lipase would be elevated to 3 times, like 3 times that of the upper limit of normal. So amylase and lipase would be very elevated, 3 times of the upper limit of normal usually. Actually, in fact, the better test is lipase. The better test is lipase. The reason for that is not because lipase is more sensitive or specific. It's just that lipase stays elevated for 14 days, whereas amylase returns to its normal like limit within 5 days. So for instance, if someone complains of epigastric pain, sharp stabbing deep pain that radiates to the back, nausea and vomiting, fever, and then they present with like Collins and Gray Turner sign, we know it's acute pancreatitis. But what if we discovered that like 7 days after the onset of the symptoms? Then when we measure amylase and lipase, amylase would have already returned back to its normal limits, whereas lipase is going to stay elevated. So that's the only reason why lipase is a better test than serum amylase. But it doesn't mean it's more specific. It just means, you know, there's more chance of us identifying acute pancreatitis, even if it's been a week since the onset of acute pancreatitis. Okay, so the next one is hypocalcemia. So this is going to come back in the lab. So typically we are going to see hypocalcemia, so low calcium in the blood, when there is acute pancreatitis. And ALT is going to be elevated, especially in the case of gallstone pancreatitis. So if gallstone is the etiology, so if gallstone is the reason for why we're seeing acute pancreatitis in this patient, ALT would be elevated 3 times of the upper limit of normal. Okay, so that points towards gallstone as the causative factor that led to acute pancreatitis, other than other etiologies like medications. You know, your protease inhibitors, hydrochlorothiazide, your exenatide, your valproic acid, or alcohol, or you know, other causes. So that's how we diagnose. So start with amylase, lipase, better test. Hypocalcemia you may see in the labs, and measure ALT. It points to gallstone pancreatitis. Okay, so now let's talk about the imaging that we use to diagnose acute pancreatitis. So the first line is CT. Okay, CT is the first line. The next one is ultrasound. So ultrasound is to see if there's any gallstones, to check for the patency of the bile duct. Okay, obviously if the bile duct is not patent, there's probably like stones lodged into the bile duct, pointing towards gallstone as potential cause of the acute pancreatitis. So first line again is CT. Next is ultrasound. Okay, gallstones. Look for the patency of the bile duct. When we do an abdominal X-ray, we can see 2 things. Okay, the first one is called the sentinel loop. So the sentinel loop is here. So you see here, sentinel loop. So the sentinel loop is ileus, or the paralysis, from nearby inflammation from the pancreas. So there's this like loop of bowel that's kind of around the pancreas, and it contains gas that's not moving along. There's paralysis or ileus of that bowel loop, okay, around the pancreas. It has air that's not moving along. That's sentinel loop. Okay, so again, sentinel loop is this loop of bowel we see around the pancreas, around the inflamed pancreas, which has gas that's not moving along. So there's ileus, there's paralysis of that loop of bowel. That's called sentinel loop. The other sign we're going to see on imaging is called the colon cutoff. So this colon cutoff is the it's like the abrupt termination of gas pattern in the colon. So if you see in this picture here, this is the transverse colon, right? The transverse colon. And in the transverse colon, you can see that gas is flowing along the transverse colon. And then when you reach the splenic flexure, when you reach the splenic flexure here, where the arrows are pointing, there's the termination of the gas pattern in the colon. There's no more gas that we see present in the colon. At this point, the bowel is decompressed. So you see this colon cutoff, where there's this abrupt termination of gas pattern, this gas flowing through the transverse colon, and then none after you reach the hepatic flexure, and sentinel loop, which is like this loop of bowel full of gas around the inflamed pancreas. So these 2 things, sentinel loop, colon cutoff. Okay, so to actually diagnose acute pancreatitis, we use a criteria, and this is called the Atlanta criteria. So the Atlanta criteria, you need at least 2 out of 3 of the following to diagnose acute pancreatitis. So the Atlanta criteria you need again 2 out of 3, right? So what are the criteria? So number 1 is increase in serum amylase or serum lipase, 3 times of the upper limit of normal. Okay, 3 times the upper limit of normal. And the epigastric pain must be consistent with acute pancreatitis. So what do we mean by this? The epigastric pain must be radiating to the back, boring in nature, so like sharp, stabbing, deep pain, and worse when laying down, better when in a fetal position, or better when leaning forwards. And obviously presenting with nausea, vomiting, and fever. So findings, number 3, findings on imaging consistent with acute pancreatitis. So you in imaging, so you're gonna do like CT. You can also do ultrasound, check for the bile duct patency, check for gallstones, and on X-ray, abdominal X-ray, you're gonna see these 2 things: sentinel loop, so that loop of bowel around the inflamed pancreas with gas trapped inside, so that portion of bowel, it's not moving, there's ileus, there's paralysis. Or this colon cut off, where you see gas moving along, flowing along the transverse colon, and when you reach the splenic flexure, there's an abrupt termination of that gas pattern that's flowing along. Okay, so 2 out of these 3 things, you can diagnose acute pancreatitis. Okay, so again, to review the Atlanta criteria, you need 2 out of 3. First one is elevated serum amylase or lipase. Number 2, epigastric pain consistent with acute pancreatitis. And number 3, imaging consistent with acute pancreatitis. Okay, so apart from the Atlanta criteria, so the Atlanta criteria we use to diagnose acute pancreatitis, right? So remember that in the Atlanta criteria, you need to have 2 out of 3 of the actual criteria to meet the diagnosis for acute pancreatitis. So number 1, again, elevated serum amylase and serum lipase. Number 2, epigastric pain consistent with acute pancreatitis. And number 3, imaging that's consistent with acute pancreatitis. So that's the Atlanta criteria. The Ranson criteria is another criteria, and this determines the severity of acute pancreatitis on admission. Okay, so if they score 3 or more in this Ranson criteria, it means that it's severe case of acute pancreatitis. If they score 2 or less, it means that severe pancreatitis is unlikely in this patient. So what are the components of the Ranson criteria? So remember, 3 and over, okay, severe pancreatitis. 2 or less, severe pancreatitis is unlikely. So what are the parameters included in Ranson criteria? So number 1 is glucose over 200, age over 55, LDH more than 350, AST more than 250, in white blood cells greater than 16,000. So I don't advise you memorizing all of this, because you could literally just Google this in practice, and I've done that. You just have to recognize them. Okay, so if someone in the exam says, how do you determine the severity of pancreatitis, of acute pancreatitis on admission of the patient, you need to quote Ranson's criteria, and you need to look at their age. Are they over 55? Check their glucose over 200, LDH over 350, white blood cells are elevated more than 16,000, and AST more than 250. So just recognize that the parameters are glucose, age, AST, LDH, and white blood cell count. Okay, and treatment for acute pancreatitis is very simple. So it's just supportive therapy. Okay, so supportive therapy means like NPO. So nil by mouth, just give the pancreas some rest, because if you're eating, you're digesting, the pancreas obviously needs to release some digestive enzymes, and that's going to stress it out even more. So supportive, nil by mouth, and just give IV fluids. Okay, and pain relief. Okay, so again, for treatment, supportive, NPO, fluids, and pain relief. Okay. Okay, so moving on to chronic pancreatitis. So chronic pancreatitis is typically the result of continuous assault to the pancreas, so continuous injury to the pancreas. So this can be from chronic inflammation, like for instance, like repetitive acute pancreatitis, that ultimately leads to loss of both the exocrine and the endocrine functions of the pancreas. Remember that the exocrine function of the pancreas is releasing digestive enzymes like amylase, lipase, trypsin to aid digestion, and the endocrine function of the pancreas includes the secretion of glucagon and insulin to regulate our blood sugar. So chronic pancreatitis, it happens because of continuous injury to the pancreas, for instance chronic inflammation or recurrent acute pancreatitis that leads to the loss of both its endocrine and exocrine functions. Okay, so it can result from multiple episodes of acute pancreatitis. We already know this. Etiology. So if you remember, the main cause of acute pancreatitis we've discussed is gallstones. 47% of the cases are caused by gallstones. For chronic pancreatitis, the main cause, the main factor I need you to remember is alcohol. So alcohol is responsible for 70% of the cases of chronic pancreatitis. Okay, so alcohol abuse. Okay, so that's the main thing you need to remember. So and the next one is idiopathic. So patients, we cannot identify like a specific cause for your chronic pancreatitis. And the next one is trauma. Okay, but the main thing I don't want you to forget is alcohol. If you're gonna forget everything else, just remember alcohol. For chronic pancreatitis, for acute, it's gallstones followed by alcohol and then injury to the pancreas. You know, I got smashed in the medications as well. Okay, so how would a patient present? So for chronic pancreatitis, we see this triad. So this, they would test you in the exams, but in reality, like in real life, only 1/3 of the patients present with this triad. So what is this triad for chronic pancreatitis? Well, we have pancreatic calcifications. We see in imaging. So pancreatic calcifications are signs of chronic inflammation of the pancreas. Okay, because of chronic inflammation, we see these calcifications in the pancreas. So that's the first part of the triad. The second component of the triad is steatorrhea. So steatorrhea is oily and fatty stools. You know, stools that look oily and fatty and would float in the toilet when they go toilet. And this is because of the inability of the pancreas to perform its exocrine functions. So without these enzymes, the body is unable to break down fat. Hence, fat is excreted with the stools, and they become fatty and they float and they look oily. Okay, that's steatorrhea. And diabetes mellitus. So diabetes mellitus reflects the loss of endocrine functions of the pancreas, inability to regulate our blood sugars. Okay, so that's the triad. So remember pancreatic calcifications because of chronic inflammation. Number 2 is the loss of exocrine functions manifested as steatorrhea, and then loss of endocrine functions, which we see as diabetes mellitus. That triad for chronic pancreatitis. But again, in real life, only like 1/3 of the patients present with all of these triad components of the triad. Next one is epigastric pain radiating to the back. Okay, similar to acute pancreatitis, you know, similar presentation, epigastric pain that radiates to the back. Okay, patients can be asymptomatic as well. So just remember the triad and the characteristic epigastric pain that radiates to the pancreatitis. Okay, so to summarize the slide, chronic pancreatitis is a result of the continuous injury to the pancreas, whether due to chronic inflammation or repetitive acute pancreatitis episodes that leads to the loss of exocrine and endocrine functions of the pancreas. In terms of etiology, the main one is alcohol, can be followed by trauma and idiopathic. Essentially all the cases for acute pancreatitis as well, because remember that a repeated acute pancreatitis can lead to chronic pancreatitis. And presentation, remember this triad, so pancreatic calcifications, steatorrhea, and diabetes mellitus, and the characteristic epigastric pain that radiates to the back. Okay, so in terms of diagnosis for chronic pancreatitis, it's not a very good idea to measure serum amylase and lipase because unlike acute pancreatitis, where amylase and lipase would be elevated 3 times the upper limit of normal, in chronic pancreatitis, amylase and lipase are usually going to be normal and sometimes even decreased because of the chronic injury to the pancreas, the production of these digestive enzymes are going to be reduced. So we don't usually use this for diagnosis, so it's not diagnostic for chronic pancreatitis because it can be normal or even decreased. X-ray and CT will show us calcification, so pancreatic calcifications, suggesting chronic inflammation, and we can do pancreatic function testing. So to test the function of the pancreas, we can do something called the fecal elastase, measure fecal elastase. So elastase, again, another enzyme that is made by the pancreas, and we measure elastase in fecal matter, so in stools, and it's typically the normal is 200 to 500. So if it's less than 200, it indicates pancreatic insufficiency. So we can use this to diagnose chronic pancreatitis. So just to summarize that, serum amylase and lipase not diagnostic. They can be normal or reduced. Imaging like X-ray, CT can show pancreatic calcifications. And the other one is measuring fecal elastase. So elastase, so doing this, it measures the activity or the function of the pancreas. So elastase is an enzyme made by the pancreas, and we can measure it in the stools. So normal is 200 to 500. So if it's less than 200, it indicates pancreatic insufficiency. And treatment for chronic pancreatitis is quite easy. The main one, obviously, because the main cause of chronic pancreatitis is alcohol, so we advise the patient to stop drinking alcohol. Second is addressing their exocrine and endocrine abnormalities. So addressing their exocrine functions first, we can give them pancreatic enzymes, replacing the pancreatic enzymes. So we can give them like Creon. So that's the brand. So it's just replacement for pancreatic enzymes. So pancrealipase, or Creon. Okay, giving replacement for those enzymes that are not being produced anymore by the pancreas due to the chronic inflammation. We can advise them to undergo a low-fat diet because, again, with the insufficiency of these digestive enzymes, we are not able to break down fat very well. So if we advise them to stick to a low-fat diet, then there's not going to be much need for these enzymes that can break down fat. Okay, and again, we give them some medications for pain control. Okay, for pain control. If they also have some endocrine problems, then we can give them a replacement for insulin, for instance. So treatment, discontinue alcohol. For exocrine function, we can give them replacements for the pancreatic enzymes. Creon is the brand. So giving them lipase, amylase. For endocrine functions, we can give them insulin. Advise them to stick to a low-fat diet, so there's not much need for the digestive enzymes. And lastly, for pain control. Okay, pain control.